Welcome ladies and gentlemen to this new video. Today we are performing another low anterior resection with TME, performed with the ArtiSential instruments and using the new STRYKER 1788 platform. So this is a 78-year-old male patient who presented with rectal adenocarcinoma located at 11 centimeters from the anal verge and who was diagnosed upon screening colonoscopy. A primary resection was decided because the patient had previously undergone radiotherapy for prostate cancer, so we subsequently performed an ArtiSential-assisted laparoscopic low anterior resection with total mesorectal excision. A protective ileostomy was fashioned. The total operative time was 210 minutes with minimal blood loss and no intraoperative complications. The patient was discharged on day 4 after surgery. Pathological examination revealed an R0 resection with good TME quality. Port placement and the intraoperative setting can be seen in the following slides. The patient being in the modified lithotomy position, we start with the dissection at the level of the trites ligament, trying to localize the inferior mesenteric vein. A medial to lateral approach is performed and dissection is carried out between the anterior renal fascia and the mesocolon. You can already see the inferior mesenteric vein at this level. Dissection is continued in a medial to lateral fashion. And the inferior mesenteric vein is now dissected. And divided between clips. To gain more length, the mesocolon is here divided, taking care that you might encounter some arteries at this level, like the meandering mesenteric artery of Moskowitz or the Royolan arc. Keeping on with the dissection in a medial to lateral fashion between the anterior renal fascia and the mesocolon. So now we turn to the mesorectal fascia and try to access it, taking advantage of the pneumoperitoneum. So you can see there how the gas helps in identifying the correct plane. You can see here the first strands of the hypogastric nerve. It's imperative at this moment to apply enough traction and counter traction to access the correct plane. If you have trouble finding the correct plane, just connect the planes at first by just dividing the peritoneum, and then with applying more traction and counter traction, basically the anatomical plane will show itself. So now we go for the inferior mesenteric artery. And there you can see it. Dissection is carried out along the lower border of the artery. And again, while preserving the branches of the superior hypogastric nerve, we just go for the artery and skeletonize it from all sides. You can see, of course, that the use of articulated instruments makes this task very much easier. The artery is clipped and divided. So now we go for the medial to lateral approach again, and dissection is carried out until the lateral abdominal wall is reached. Also here it's imperative to apply enough traction and counter traction to find the correct plane, and indeed to preserve all the important structures like the left ureter, the left iliac vessels, and the left hypogastric nerve. You can see here that we are doing already parts of the TME, at least the upper parts of the TME, and this will make it much easier to continue this task from the lateral side. You will see this in a moment. It's very important here to take your time and do a very meticulous dissection to avoid any injuries to important structures. Here we keep going with the upper parts of the TME, again preserving the superior hypogastric nerve, here the right side. Your assistant can provide at least some parts of the traction and the counter traction. So once the lateral abdominal wall has been reached through the lateral medial to lateral dissection, we go then for the lateral dissection and try to join the planes. We start here the lateral dissection at the level of the sigmoid colon, trying to avoid opening the peritoneum, because if you open the peritoneum at this level, you will simply lose your plane. It might happen sometimes, but you'll have to correct this and just try to find the plane again. And once the planes are connected, the rest is very easy to perform. Dissection is then continued in a cranial and a caudal manner. Some adhesions are removed. And joining the planes is continued. And once you realize that you're not getting enough traction and counter traction, it will be time to bring the patient in a right-sided tilted position so as to take down the splenic flexure. And we will do this in a moment. So the patient is now brought in a tilted right-sided position. And now we go for the gastrocolic ligament, which will be divided in a moment, and the lesser sac is accessed. Also here it's absolutely important that the assistant provides enough counter traction. You can just apply traction to the upper border of the colon. So the lesser sac is now accessed. And we just keep on dissecting in a right to left fashion so that we can take down the splenic flexure by dividing the splenocolic ligament. So you nearly always have this kind of ring of fat surrounding the splenic flexure, and it needs to be divided. And once this ring is divided, you are going to join the planes. Basically, the plane which we have created from performing the lateral dissection, and the plane which we have encountered by accessing the lesser sac. And it is exactly at this moment that you will notice the lower border of the pancreas. And there you can see the pancreas already. And to achieve more colonic length, you are just going to perform dissection at the lower border of the pancreas. This is completely avascular tissue. And if you still need more colonic length for the anastomosis, you can still keep on dividing the gastrocolic ligament and basically mobilizing the transverse colon. So we go back to the modified lithotomy position and we continue our TME. You can appreciate here the advantage of having done a considerable part of the TME from the mediolateral aspect. Dissection is continued from the left side. Also here preserving the left-sided hypogastric nerve. Of course, the advantages here of articulation are very evident. The peritoneum is incised. On the ventral aspect of the rectum, so we can access the Denevillier's fascia in a moment. TME is continued from the right side, again taking care and preserving the hypogastric nerves, and then the peritoneum is incised ventrally and dissection is initiated along the Dennevilliers fascia. Again, it's very crucial to provide traction and counter traction. The assistant here plays a very crucial role in providing the counter traction. The greatest advantage here of articulation is that you can always stay in the right anatomical plane without exerting any tension or strain on very delicate structures like the seminal vesicles. There is no thermal injury to these structures. Again, here you can see the nerves very nicely. And the TME is continued from the dorsal side and from the right side. You can also here appreciate the advantage of having a bipolar forceps in the left hand, so you can take care of these very small bleeds immediately without having to change instruments and without having to interrupt your workflow. Dissection is continued in a circular manner, taking care to keep the whole mesorectum intact. Once you notice you're not making any progress at one side, just switch to the other side. You have seen here we were dissecting at the ventral aspect. So once you notice you're not making any progress, just go to somewhere else, like the dorsal part of the TME, and you will notice that you will immediately start to make progress and going forward with your TME. So this is a male patient with a BMI of 31, and despite obesity, you still have an excellent view. And this is actually only possible due to excellent instrumentation and of course an excellent platform. So you see here we have stopped to have any progress on the right side, so we go to the left side, and it's always the same principle. Once you notice you're not making any progress at one part of the TME, just go to the other side and you will immediately notice the change. Again, here a very small bleed which you can take care of with the bipolar forceps with relative ease. So you can notice that we are now at the very last parts of the TME, and you will start to see now skeletonized rectum, which is basically a sign for you that you have completed the TME. So there is no fatty tissue to see, and this is the notice for you that you have completed your TME. Here are the last parts on the dorsal side. You can see here parts of the levator muscle. Also on the right side. And once you have skeletonized the rectum at this level, you will be able to bring in the stapler in a very easy manner. So we're stapling the rectum here with a green load. It's a 60mm echelon. Of course, if you have performed the complete TME, mostly you will be successful in doing a stapling with only one load. It's also a great help to have an articulated forceps during this step, because you are able to push in the rectum inside the stapler from the left side, preventing the rectum just to slip outside the stapler branches. And you can see here the stapler the stapling process was successful with only one load. So we're going to exteriorize our specimen now. It will be done with an incision performed in the left lower quadrant, about 3 centimeter length. We always do fluorescence using indocyanine green. The colon had been extracorporeally skeletonized before performing fluorescence. So now we go for the anastomosis. This is double stapled anastomosis using a 29 millimeter echelon circular stapler. We always perform a side-to-end anastomosis after doing a low anterior resection with TME. An air leak test is performed using colonoscopy. We still put drains during low anterior resections, but we have abandoned this in all other kinds of colorectal resections. A protective loop ileostomy is then created. Our TME specimen can be observed on these slides, as well as the distal resection margin. So that's about it for this time. I hope you will join us for the next video. Bye bye.